start this afternoon with advanced imaging in the maxillofacial region to complement the two talks from this morning. So we're going to go through imaging techniques, a few applications, and common pathology. So the imaging techniques available are radiography, and we've talked about dental panoramic tomography, or the OPG, and the value of high-resolution intraoral imaging as done by dentists, cone beam imaging, which I'm going to talk about first, multi-detector CT, ultrasound a little bit, MRI a little bit, and nukes. Can I just ask if anybody has cone beam imaging, uses it on a regular basis? Okay, one person. That's the lady from South Australia. Yeah. Okay.
I think there's one in Hobart.
Okay. Okay, so I think it's important for us to know about cone beam, because cone beam's not just in the realm of dental radiology, it's now coming into orthopedics quite a lot. And there's a specific machine just come out, I saw advertised for cone beam imaging of the foot, but it's being used for the hand as well. So it's basically a cone-shaped X-ray beam, hence the name cone beam. It's a pulsed beam to reduce the dose, and there's a single rotation around the patient. The image detector, they're virtually all flat panel solid state now. In the early days of dental machines, there were some inferior systems, which I'll just touch on briefly. And you have a computer restructuring of a volume data set. So this is an ICAT cone beam machine. It's the one that we use. The cone beam technology, single rotation, scan time's about 15 seconds on average. So it's comparatively slow as compared with CT of the same region, as compared with conventional CT, where you have a fan-shaped beam and the patient's lying on their back. So there is only one brand of cone beam machine where the patient actually lies flat. That's the Nutom, made in Verona in Italy, and they are a very nice machine. So conventional multi-detector CT. Just a little bit about radiation. Background dose in Australia is 2.1 millisieverts per year, but that's equivalent to 160 OPGs. If you smoke, 13 millisieverts per year, 1,000 OPGs. Living indoors, just being inside property, 0.75 millisievert. Watching TV, a little bit. Air travel, 13 OPGs. So 1 millisievert, 1,000 microsievert, 1 OPG dose, approximately 13 microsieverts. So we're going to use this in comparison to what we're talking about now. So as we know, there's been a lot of hype in the press over the last 3 to 4 years over radiation, and one began to think that we were becoming the Grim Reaper. Comparing the three most common modalities used in maxillofacial radiology, no volume data set with a DPT. It's a direct volume with cone beam, unlike CT where it's indirect. The resolution of cone beam is slightly higher. There's no soft tissue contrast with cone beam. And the radiation dose is nowhere near what it's been stated to be in the dental literature, the differences in the radiation dose. So a cone beam, an average dose for an average study, 75 microsieverts, so about 5 times an OPG. And the CT dose, what we would achieve if we consider that would be a good max FAC examination, would be about 200 microsievert. As I said, most of the literature pertaining to cone beam over the last 15 years has been in the dental literature. Most of it's very poorly written. It's been indirectly or directly financed by the companies that make the machines. And it perpetuates the same rubbish in numerous statements, such that one of the surgeons who doesn't like it gave it the nickname of con beam. The doses we've seen, they vary tremendously according to who you read, but all the cone beam, a lot of the cone beam literature will refer to doses from CT dating back to the mid-90s or even earlier. So it does have higher resolution. CT voxel length 0.625, cone beam voxel length, exquisite detail of the lamina dura and the periodontal ligament space on cone beam. It's certainly not 10 times better than a medical CT, and that's the other thing. They love to call conventional CT medical CT. The other thing is, the other misnomers they love, that cone beam was introduced by the dental profession. It wasn't. It's been around for years, and it has multiple other uses. One of the beauties of cone beam is that the streak artifact is significantly less than it is with CT. This is the same patient. You can see the improvement in the streak artifact, particularly from that 2.7. And it tends to be more focal to the area where it is produced, rather than degrading imaging on the other side of the arch. As you can see, where we're looking at the upper right central incisor on the CT and the cone beam, and you can see the arch, you can see the tooth a lot more clearly than you can on the CT scan. But there's no soft tissue detail, and unfortunately you do see some, they're not misses because it's just not there. There's the same patient with pain in the floor of the mouth, referred from a dentist, mandibular calculus or something, I don't know, and there's a big infiltrating carcinoma. You would think that would be evident clinically, but obviously not in this case. So if we compare, cone beam's a lower dose, multi-detector CT is a low dose. They're both high spatial resolution, cone beam slightly better, less streak artifact with cone beam, soft tissue outline but no internal detail, and we know that CT soft tissue contrast is good and it's improved by intravenous contrast. Cone beam is tightly controlled in certain states anyway, and the laws pertaining to who can use it vary from state to state. In WA, you have to be a radiologist, and a radiographer have to run a cone beam unit. It cannot be run by a radiographer on its own or a clinician. So it does vary from state to state. CT is widely available. The majority of the literature pertaining to cone beam is poor, and multi-detector CT is the gold standard in dental and maxillofacial radiology. So cone beam is an excellent low-dose technique, but it's open to abuse unless you define the indications. And multi-detector CT remains the gold standard. So comparing types of cone beam, the dose can vary tremendously. And, you know, you've got to talk about apples and apples, basically. ICAT is the commonest used variety of cone beam throughout the world, so that's what we will compare with. As I said, the detector systems are virtually all now solid-state flat panel detectors. Where they do vary is the field of view. And it's got to be, to make a difference to dose, you've got to be able to scan on limited volume. And a lot of the earlier cone beam machines couldn't do that. But now you can vary. You can vary voxel size, which will obviously vary resolution as well. And the position in which the patient is scanned is most commonly standing or sitting. Now, this is comparing image intensifier cone beam with flat panel detector, and they're like chalk and cheese. So these have largely gone the fixed field of view, image intensifier related systems, a lot of geometric distortion at the periphery of the image. And again, you should be able to vary your volume. You can vary your radial recons, just like doing a CT. You can do panoramas, just like a CT dent scan, and you can do 3Ds, just like CT. And you now, with some of the smaller systems, you can do a single arch, a quadrant, or even 3 teeth or 2 teeth, further decreasing the dose. So when do we use cone beam? Well, obviously in younger patients, it's a dose issue. We use it for assessing dental implants. It's the best means, it's better than CT. We use it for equivocal lesions on an OPG or a DPT, unruptured or impacted teeth, selective orthodontic analysis and not routine orthodontic assessment. And these are some of the grey, or in this case pale blue areas: odontogenic cysts and tumours, TMJ, routine orthodontic assessment, airway evaluation and dental sepsis. I personally don't use it for any of those. And there's good reasons why. So what can we use it for? Well, what I want to discuss briefly is give you an overview of how you would apply CT in particular, conventional CT, to evaluate complicated infection, odontogenic cysts and tumours, non-odontogenic lesions and fibro-osseous lesions. Now, just to make sure that you took in something this morning, which I know you did, periapical sepsis, endodontic, okay, inside, caries, trauma, non-vital tooth, spreads down the root canal, gives you a tooth which is painful to bite on. Okay, periodontal disease around the tooth results from plaque and biofoam, and the tooth is alive or vital. So caries, see the carious lesions, inflames the pulp, which undergoes necrosis, infection, leads to apical periodontitis with widening of the apical periodontal ligament space, demineralization of the lamina dura, which can be acute or it can be chronic. So acute or acute on chronic periapical sepsis. It's a very common presentation to emergency departments, or the sequelae of it are, or even to GPs. It doesn't always go to the dentist. So you get ill-defined lucency, so-called apical rarefaction. The OPG is very, very hard to see the sepsis associated with 4-7. It's more clearly evident on the thick slice MIP that I've done from the axial data set on my workstation. The apices are below the mylohyoid muscle because it's second molar. Therefore, the spread of sepsis will be inferiorly, like the case of the fistula we saw in this early sepsis in the submandibular space. A bit of edema, a bit of thickening of platysma. Okay, more significant infection. And these abscesses don't have to be big to cause serious problems, okay? This is a sublingual, a subperiosteal abscess. In the sublingual space, it's above mylohyoid. Despite the fact it's a second molar sepsis can go above mylohyoid sublingually or inferior to mylohyoid in the submandibular. Third molars always go below mylohyoid, and the first molar goes above mylohyoid. So it depends where the tooth roots are and where your mylohyoid attaches. And that will vary from person to person. Okay, acute on chronic infection, this time it's gone buccally. 4-6. Okay, it hasn't gone lingually this time, above or below mylohyoid, it's gone buccally. And you don't have to have a perforation of the cortex to have a collection. There's obviously Haversian canals, there's thin roots in which sepsis can get out and form subperiosteal pus. So don't think that because I haven't got a hole in the cortex, I can't have an abscess adjacent to the bone. You can. One of the things which we're seeing increasingly as oral hygiene and visits to the dentist are becoming less frequent, particularly among people who don't have the money to afford routine dental treatment or choose not to, is complicated dental sepsis. There is an entity called Ludwig's angina, which is an entity of trans-spatial cellulitis, and it has a high morbidity and mortality. And really, that morbidity and mortality has not really altered very much over the last 20 to 30 years. And people will still die of this condition in Australia every year in major public hospitals. So what you get is basically a phlegmon, and you get abscess formation, but the abscess isn't the predominant feature. So when we look at it, there's actually edema everywhere. It's just more pronounced on the right. So here we can see our gas-producing organisms spreading through mylohyoid, going into the submental space. We can see edema of the airway. You can look how narrow the oropharynx is in the sagittal reconstruction. And what is the culprit? The culprit is distal caries in 4-6 with the most subtle periapical sepsis, which again see more clearly on the thick slice MIP. And that was the cause of the patient's Ludwig's angina. There's no cortical fistula, nothing. So if you see odd edema and sepsis in the head and neck, look at the teeth. That's the take-home message. It may be more obvious. This is, I think Gav showed this case, or it's a very similar case to the one he showed in his opaque antrum talk, where we get an opaque right antrum. If you see a unilateral opaque sinus, I mean, we went through the messages. We look at the density of it, but we also check the tooth roots, okay? So the osteomiated unit's occluded. There's a carious 1-8, And there's the periapical abscess with the hole in the floor of the right maxillary sinus. And then we have caries on the other side in 2.7 and 2.8. And you can see the CT beautifully demonstrates the spread of caries within the dentine as compared with the enamel. Periodontitis, we already talked about. We can grade it: mild, moderate, severe, horizontal or vertical. This is aggressive vertical periodontitis. These teeth will be loose. And then the combined endodontic periodontic lesion with a very nice example of root resorption. And this is not mucosal cancer, this is periodontitis. And you can see the severe disease elsewhere with calculus deposits. So getting on to the specific lesions, we've talked about apical radicular cysts, we've talked about dentigerous cysts. I'm only going to talk about 4 lesions because they're the commonest ones that you'll come into contact with. The things to consider are the relationship to the tooth. Is the tooth erupted or unerupted? Is it associated with the apex or the crown? The site and the size, which jaw, anterior or posterior? The margin, is it well defined, poorly defined? Does it have a sclerotic margin? Is it uniloculate, multiloculate, so you can actually, multilobulate, so it has a corrugated margin, or is it multiloculate with locules separated by septa? And is it expansile? Does it cause cortical thinning or perforation? And what are its contents? Attenuation, signal, calcification or enhancement. And this again is one of the weaknesses of cone beam in evaluating odontogenic cysts and tumours. You can't tell what's inside it unless it's calcified. And the relationships, the anatomical relationships. So here's an apical radicular cyst, that's commonest dental cyst, root of a non-vital or dead tooth. Common in the anterior maxilla due to trauma. They're related to the apex unless the tooth is removed, when it becomes a residual cyst. And you remember the differential, we said a cutoff point of 10 millimetres. A bit of calcification in that, probably a little bit of cortex or a bit of chronic inflammation. Apical radicular cyst, this is from caries, 4-4, thick slice MIP, fluid attenuation, middle-aged males most commonly, and then a large apical radicular cyst associated with, take your pick, but probably 2.6. Probably 2.6. And we see the elevated antral floor, the sign that Gavin was talking about as a reliable fact indicating that it's of odontogenic origin. The dentigerous cyst, it's around the crown of a tooth, not the apex, and it only develops in a tooth which doesn't erupt. So that's going to be your third molar or your maxillary canine. And we've got mesoangular impaction of 4.8. We've got a bilobulate 3 centimetre dentigerous cyst. We note its relationship to the infraalveolar canal, which is inferiorly displaced. We describe that, and we describe any root resorption of adjacent teeth. This is a nice example because this is so-called collapsing or inflamed dentigerous cysts where the walls become thick and inflamed, and it illustrates a beautiful point of the elevation of the floor of the antrum by the impacted tooth. And note, it's attached to the melo-cemental junction, meaning the bit where the enamel is switching over to the dentine. And it doesn't have to be the whole circumference around the tooth. It can be asymmetric, but at least part of it has to have that relationship, which we can see beautifully here. And of these, 25% in the maxilla. Here's one associated with 1.8. They're uniloculate, they're expansile, fluid attenuation, and 75% in the mandible, here associated with 3.8. Now, I just realised there's a mistake on that slide. That should be KCOT. Isn't it amazing how many times you look at lectures and then you put it up on the screen and you see the glaring error? So this is what used to be called an odontogenic keratocyst. And they've now been reclassified as a tumour in 2006 and given the name of keratocystic odontogenic tumour. The major differential is the ameloblastoma. Now, it says KCOTs are less common than ameloblastomas. I've taken that from my book, but it's just not true. We see way more KCOTs. We probably see 1 or 2 a month as compared with ameloblastomas where we probably see 1 or 2 a year. from a big referral base. Age, they're KCOTs in the younger age group. They have an association with Gorlin syndrome, which is good for the registrars, the basal nevus jaw cyst and bifid rib syndrome. And ameloblastomas occasionally become malignant, and they can, like pleomorphic adenomas, metastasize even when they're not malignant. So it's quite a complex subject. Both recur, and that's why they're important lesions. Now, KCOTs used to be excised. They tend to now to be drained, and they put up this really toxic material which into the cyst cavity, which kills the lining, which is a friable layer of non-keratinized epithelium. So a thin layer of keratinized epithelium. And it kills those cells, the lesion shrinks down, and if there's any residual lesion left, they excise it. Whereas ameloblastomas require radical resection, both require CT follow-up. They both predominate in the posterior mandible, and they tend to be multiloculate in the mandible and uniloculate in the maxilla. 50% of KCOTs are related to the crown of an unerupted tooth. So that immediately tells you that they may look identical to a dentigerous cyst, okay? Whereas ameloblastomas tend to push teeth away or they replace a tooth. They don't have that dentigerous relationship. It is said that ameloblastomas are more expansile and they have thick septa, whereas KCOTs spread along the length of the bone. One of the things that Gavin showed today was the hyperdense keratin debris in KCOT. It's pathognomonic of that lesion. Ameloblastomas are variable. It can be cystic, solid, or a mixture of the both. KCOTs don't enhance, ameloblastomas do, and the MRI equivalent of the hyperdense keratin is the T2 dropout, and more recently described restricted diffusion. So this is a KCOT, reclassified. See the elevated antral floor, and you see it can be quite tricky to actually see that line. It's a multilobulate lesion. It's not got septi dividing it to call it multiloculate, but it has a multilobulate outline. And on the soft tissue windows, it shows a beautiful demonstration of keratin debris. It's big. It's expansile. You know, I think that thing that ameloblastomas are more expansile or KCOTs not that expansile generally comes from plain radiography descriptions. The commonest site KCOT is posterior mandible. This one is not associated with erupted teeth. There's our thick MIPS. There's our T2 dropout due to keratin. There's T2 with dropout, T1 with some hyperintensity and no enhancement following GAD. T1 axial, faintly hyperintense, and quite significant restricted diffusion. Now, KCOTs, we've said, may be multiloculate, and this lesion, you could never say this wasn't a ameloblastoma. It would depend on the age, but you'd have to give two differentials, basically. So 3/8 is absent, so that doesn't help you. It's extended from the coronoid notch to the 3-3 region. So T2 dropout on MR, multiloculate on the thick slice MIP, 3/8 is absent. And as I said, they're said to have more AP extension than buccolingual expansion. This is very like the case, Raj, that you showed me on Thursday night. And again, note the displacement of the infraalveolar canal. The surgeon wants to know where the infraalveolar canal and the mental foramen are. Okay, bright on T2. It's a little bit of dropout, but predominantly bright on T2. And this is a different case and just shows you how they used to be managed with surgery and how they can recur. So preoperative large multilocular lesion, en bloc resection, bone graft reconstruction. You can never diagnose recurrences of these unless they're gross on plain film imaging. And there's soft tissue recurrent OKC, and that's surgically proven. Ameloblastomas can look identical to that multiloculate lesion, very, very expansile, a lot of bone erosion and destruction. Okay, 3D images, yeah, they're very pretty, but they don't really add anything. But you can see the soft tissue attenuation on CT and the patchy enhancement following contrast. Recurrence said to be 15%, and really quite dependent on how much you're and how aggressive you're prepared to be in removing these tumours from the outset. This is recurrent tumour, multiloculate, markedly expansile. It's gone up to a costochondral graft following excision of the condylar head. Soft tissue spread into the infratemporal fossa and the temporal fossa. And then you can diagnose tumours around the maxilla and paranasal sinuses in the most strange ways. We were asked to do an ultrasound of this case. So we did that was the first examination where you could see it was actually arising in the alveolar process. And it was obviously a solid tumour with cystic spaces. And then on the CT, you can see the elevated sinus floor. It's not fluid attenuation. It could be a KCOT, it could be a residual cyst, it could be a CEMENTOBLASTOMA. Okay, MR will sort it for you. It's bright on T2, no T2 dropout, intermediate to low T1, heterogeneous enhancement. Okay, aggressive bone destruction. I think I showed this case in the quiz. This is squamous cell carcinoma. And remember that involvement of the infraalveolar canal classifies that tumour as T4B, gives you a very poor prognosis. So fibro-osseous lesions. The two lesions Gav showed already, fibrous dysplasia and cemento-ossing fibroma, and then the other sclerotic lesions, which really you'd have to be a pervert to enjoy. Fibrous dysplasia, interesting, you know, it's ground glass, it does cross the midline. You know, it's just like this rule that never say never. Most of the time they will bulge across the midline and they don't cross where the embryological suture line would have been. This case is, but it's obvious FD. This is fibrous dysplasia involving the maxilla, encasing the right infraorbital nerve on your left side, patient with facial pain, and then the craniofacial fibrous dysplasia that flows from one bone to the other. Now that is technically still monostotic fibrous dysplasia if there was no other site in the body affected by that process, despite the fact it's involving multiple craniofacial bones. The ossifying fibroma, or cemento-ossifying fibroma, is a circumscribed lesion with corticated margin. You can distinguish them histologically and as well as I think genetically they're quite different as well. This is a circumscribed lesion with a corticated, marginal lucency and possibly an outer cortical margin, different densities within the lesion. It's not attached to a tooth root, but it abuts tooth roots. And again, displacing the mental foramen and an infraalveolar canal. You've seen some of these sclerotic lesions in several of the talks. There are a couple of references. There's even more detailed ones than this, which, you know, they're good for insomnia. So tori, I like tori. They fascinate me because, you know, why do they appear in middle age? Nobody really knows, and they're also commoner in Red Indians and Eskimos. There you are. So these are midline palatal tori, and then because it's dentistry, they're midline palatal tori. If they occur on the buccal or palatal cortex of the maxilla, they change the name to exostoses. But if they appear in the lingual cortex, the mandible, and the canine and premolar region, they become tori again. Okay, but they're developmental exostoses anyway. Then you can get hematomas, which are elements, dental elements of varying degrees of complexity and organisation, which are a benign hematoma, which we see an example at the top, where you can see numerous dental elements. They may replace a teeth or be supplemental to a tooth. And in that particular case of the image at the top, you can see, I'm shouting it at myself, what am I doing? Okay, you can see that it's actually 5-5 is absent. This is 8-5. There's the first premolar here, and this is the odontoma or hamartoma. Then the simplest form of an odontome is really a supernumerary, which we have here. Okay, they could be classified as a simple odontome. And then of the ones that are bizarre, you can either get ones where you can recognise teeth in, where you call them compound, or where you get disorganisation of tissues. Like here we have extra teeth, but we also have a sclerotic area as well. So that would be complex. Well, it's in between a compound and complex. So the complex ones are very uncommon, but can look quite bizarre. So it's something to think of if you see an erupted collection of teeth. It looks a bit like an ovarian teratoma, doesn't it? There's a half compound, half complex, or it's two supernumerary teeth with a bone island or enostosis by the side of it. It's really is fun trying to classify these things. And then we've got idiopathic osteosclerosis, also known as enostosis or bone island. Common, adjacent to root or apex, non-expansile, irregular in shape. Merges with the cortices, the lamina dura, and the margins of the infraalveolar canal. Okay, and that's a classic appearance on CT, where you see that diffuse abutment or fusion to the cortex. And even they can even encircle the infraalveolar canal. If you see that, it's a bone island. It's a no-touch lesion. And then rarities. The cementoblastoma is a true tumour, benign tumour, arising from the cementum of the root. So it's fused to the root, as you can see with this lesion. And it has a marginal lucent margin. Okay, so that's the cementoblastoma, very rare. And then you can get these oddities, which have now been reclassified, exciting as it might seem, from periapical segmental dysplasia to osseous dysplasia. It's not really surprising because they don't actually arise from cementum, they arise from the bone around the apical region and the lamina dura. So, excuse me. Just go back to where I was. So they're fused, so periapical osseous dysplasia may be around one tooth, the teeth will be vital, or it may be around multiple teeth, as in this particular case, where we've got sclerotic lesions of varying maturity associated with several teeth in the mandible. And that's given the name of florid periapical osseous dysplasia. Right? They're vital teeth, that's the important thing. Now, just to move away to a few simple things, thank God. Non-odontogenic cysts. So simple bone cyst, younger people, no epithelial lining, thought to be due to trauma, so-called traumatic or simple bone cyst. They're slightly expansile, they scallop the cortex, anterior posterior mandible most commonly, and they can grow up towards the crestal margin between the intact roots of teeth. So they don't cause root resorption, the teeth are vital, and they contain fluid. They're uniloculate. Nasopalatine duct cyst, also known as an incisive canal cyst. They arise in the nasopalatine duct. There's two paired neurovascular canals passing from the nasal septum down towards the incisive foramen behind your central incisor teeth. You may get a developmental cyst. And they can be heart-shaped, again, as per the lesion that Raj showed me on Thursday night. The nasolabial cyst, it is a soft tissue fissural cyst between the median and lateral maxillary processes. It often presents to GPs rather than to dentists because there's no dental connotations apart from osseous scalloping. And they may be, but I've seen them bilateral as well. This one's of proteinaceous content, cystic on ultrasound, and it's causing some osseous scalloping. The teeth are vital. STAFNE'S bone cyst is not actually a cyst. It's one of the few lesions which occurs inferior to the infraalveolar canal that you'll find in dental textbooks. And it is a developmental defect in the lingual cortex and marrow. It occurs inferior to the infraalveolar foramen, and it may contain submandibular salivary gland tissue. Okay, there's our oblique lip, and there's a bit of salivary gland tissue going up to it, which I think you can just see here. So I've tried to give you a potpourri really of interesting cases where I think there may be of value to you in general practice where you see some CT in the maxillofacial region. Keep it simple, keep a narrow differential, and if you're unsure, ask for help. Again, that article is quite useful if you just want to look at some of the imaging of the more common lesions from a few years ago. Okay, thank you.